Good afternoon, everybody.
Good
Um,
afternoon.
I'll be presenting Tinea Capitis and the African Child. I like that this came right after the presentation on pediatric mycology because this has to do with the African child. Next slide, please. So my presentation is basically in two parts. I'll give an overview of Tinea Capitis, and then I will talk a little bit about a study that was recently done, a systematic review to estimate the burden of Tinea Capitis in African children, and then conclude. Next slide, please. So Tinea capitis, or scalp ringworm, is a contagious superficial mycosis of the scalp and the associated hair follicles. It's a very common ailment. It occurs predominantly in children under 12 years of age, although it can affect all age groups. But it's a common ailment and it's found mostly in children. The true burden, however, is unknown. It may be caused by dermatophyte fungi of either genera of Microsporum or Trichophyton. It's most common in areas where you have a hot, humid climate, which favors the growth of dermatophytes. So in Africa, Southeast Asia, and Central America. And in these locations, there are specific children or individuals that may have greater predispositions, poor hygiene, overcrowding, sharing of personal materials like clothing, towels, and so on. And then this important predisposition, little or absent cutaneous saturated fatty acids that you would usually provide a natural protective mechanism against dermatophytes. So this could be the reason why it's common in children and more so in malnourished children. The clinical features range from from non-inflammatory to inflammatory. So you can have symptoms ranging from scalp scaling, pruritus, erythema, hair loss, which is alopecia, pustules, inflammatory swelling, and lymphadenopathy. The pathology will often depend on infecting species. So you can have ectotrix, endotrix, favus, and carrion. I won't go too deep into that, but those are different manifestations. So on the right-hand side, you can see what we typically call carrion. It's a very inflammatory lesion, and it could be caused by um, uh, zoophilic dermatophytes. That's when you get it from the types that you find in animals like cats and dogs. Next slide, please. The diagnosis is mostly clinical. You may find patchy hair loss in a ring pattern. And then you can also use what we call Wood's light, which is just long wavelength ultraviolet light. This is mostly used for the diagnosis of microsporum species. But Trichophyton choleni may also flourish with Wood's light. And then potassium hydroxide microscopy is also very useful, and culture. Next slide, please. Okay, sorry, treatment. I'll go with the treatment. Treatment is advocated to be systemic, okay, with griseofulvin for 4 to 8 weeks. There are some alternatives like the fluconazole, itraconazole, or terbinafine. Antifungal shampoos may be used, but only as a supplement and not as the mainstay of therapy. And the prognosis is usually good when treatment is adhered to for the correct duration. Complications of tinea capitis: hair loss. There can be loss of self-esteem, and people that suffer from tinea capitis can be ridiculed. Either they are bullied or they are isolated. There can be loss of concentration due to intense pruritus and poor academic performance. There may also be emotional impairments. A study done in Rivers State showed that more than half of children that had tinea capitis had psychosocial impact. Okay, so when you look at these complications, you can imagine if the number of children that suffer from tinea capitis, are we really looking at the serious complications, or do we just pay attention to the cosmesis? Next slide. Okay, so this brought about the study which was done in 2020. The study was to estimate the burden of tinea capitis among children in Africa. It was led by Dr. Bongo Min in Uganda. A couple of Ugandan folks and my humble self from West Africa, we did this estimation of the burden of Tinea capitis among children in Africa. Next slide, please. The objectives of the study were to evaluate the burden, the etiology and trend of Tinea capitis among African children over a 30-year period. Okay, so spanning from 1990, January 1990 to October 2020. The specific objectives were to estimate the pooled prevalence of Tinea capitis and the country-specific prevalence, as well as the number of children with Tinea capitis in various countries, and also to look at culture-proven etiologies, at least to genus level. Next slide. So it was a systematic review of studies identified via Embase, Medline, and the Cochrane Library over the span of 30 years, like I said. A meta-analysis was done to find the pooled prevalence of Tinea capitis in African children. We used United Nations Development Program figures to estimate the total and regional burdens. The findings include that the pooled prevalence of Tinea capitis in Africa is 23%. So you can see it's close to what the previous presenter said about the prevalence in Nigeria. So it's 23%. And this amounts to 138 million cases of Tinea capitis occurring yearly in Africa, okay, based on the population of children, which is about 0.6 billion. 96% of these cases occur in sub-Saharan Africa. And when you look at the country-wise breakdown, you find that Nigeria topped the list, with accounting for 16.4% of cases, followed by Ethiopia, which contributes 8.5% of cases. Regionally, more than a third of cases were from West Africa and close to a third from East Africa. So West Africa and East Africa together account for about 2/3 of the cases of Tinea capitis. Next slide. And comparing this to the recent estimates from individual countries conducted by Life, they were relatively higher, although the one for Nigeria is close. One for Nigeria is about 20 million or so, and that's close to what was estimated. Now, for the species, it was mostly trichophyton species. Close to 70% were trichophyton species, and another 30% due to microsporum species. So we estimated the burden of Tinea capitis, but there are still some gray areas, some areas where we don't really know the burden of morbidity. Okay, we don't know the impact of HIV on the burden of Tinea capitis because many of the studies didn't really look at what impact HIV had on Tinea capitis. We don't know the morbidity burden as per alopecia, carrion. These are things that can affect the psyche of children even into adulthood. When you have alopecia that is not reversible, and especially in females, you can have psychological issues, and the number of psychosocial impact studies are very few. So it seems that more emphasis has been placed on cosmesis and all that, but not much has been done about the psychosocial impact on these children. Just a few studies, just one from Nigeria that really talked about the psychosocial impact on Nigerian children. And then we don't know much about the co-prevalence with other dermatoses such as pediculosis, that's head lice, and Tinea corporis. Next slide. Next slide, please. Okay, so when you see a scalp lesion, is usually perceived as trivial to the observer, connotes intense discomfort for the child. So in conclusion, this study found that 1 in 5 children in Africa has Tinea capitis. Close to 70% of these are in West and East Africa. Tinea capitis can be regarded as a neglected tropical disease. Okay, it's common, but it's neglected globally, and it's a public health problem in African children. So the precise quantification is required to inform clinical and public health intervention strategies. Next slide. These are my references. Next slide. This is where I work, University of Benin Teaching Hospital. Thank you very much for listening.